On behalf of ISCH, I welcome you all to the ISCH webinar series. Today's presentation is titled Long-Term Outcome of Therapy for Pediatric Acute Myeloid Leukemia. It will be presented by my friend, colleague, and well-known leader in the field, Dr. Neil Butt. Dr. Neil Butt is an associate professor in clinical research division at famous transplant program at Fred Hutch. He's associate professor of pediatrics in division of hematology and oncology and bone marrow transplant cell therapy at University of Washington. Understanding and mitigating challenges, these are his expertise in long-term cancer and transplant survivor after completion of therapy. His research also includes developing new therapeutic options for leukemia and understanding and mitigating challenges faced by long-term transplant and cancer survivor. Neil, floor is yours. Thank you again.
So in next 45 minutes or so, I will try to discuss these objectives. So first, I will briefly review the long-term risk associated with childhood cancer and its therapy. Then I will specifically use a patient vignette and discuss the complications of survivors of acute myeloid leukemia who have been treated with chemotherapy with or without stem cell transplant. And then I will spend some time in discussing potential ways to prevent and mitigate these late effects and some unknown topics in this field. So this slide just highlights the spectrum of physical and psychological long-term complications that childhood cancer survivors are at risk for developing. These complications can affect survivors' growth and development, organ function, fertility and reproduction, risk of subsequent carcinogenesis, and psychosocial health. This late effects could be related to any specific type of treatment exposure or because of general cancer experience. And then the data shows that all long-term survivors report at least one late effect after completion of therapy. Now, if we talk specifically about pediatric acute myeloid leukemia, the literature has shown that the short-term survival has significantly improved in last several years, mainly because of identification of high-risk groups, several efforts from several collaborative consortia, and then also optimizing treatment strategy and supportive care. However, despite that, the risk of late morbidity and mortality in AML population still remains high. Uh, a, a study from Childhood Cancer Survivors Study, which is the largest cohort of childhood cancer survivors in North America, they found that 5-year childhood cancer survivors had a very high risk of late mortality, almost 11 folds higher compared to the general population. This was the highest among patients with hematologic malignancies, and the only higher risk of late mortality was in patients with CNS tumor and Ewing sarcoma. Another study from St. Jude Lifetime Cohort, focusing on 10-year survivors of childhood cancer, showed that the cumulative burden of chronic health conditions was highest among survivors of AML compared to other hematologic malignancies. This figure on the right shows the cumulative burden of grade 3 to 5, which is highest burden of severe life-threatening conditions and conditions that can lead to mortality. As a next step, we conducted another analysis specifically focused on survivors of acute myeloid leukemia and compared the cumulative burden of grade 1 to 4 CTCAE conditions and grade 2 to 4 CTCAE conditions between AML survivors treated with stem cell transplant, AML survivors treated with chemotherapy alone, and general population controls. Where grade 1 and 2 mean mild or subclinical and moderate conditions, and grade 3 to 4 are severe and life-threatening conditions, as I mentioned before. We found that by age 40, the highest number of conditions were seen in transplant survivors, followed by survivors treated with chemotherapy alone, and then followed by the general population controls. So with that background, I'll share this vignette with you. So this is a patient SB who is 9-year-old female with no significant past medical history and presents to an emergency department with fever and fatigue. The complete blood count shows elevated white blood cell and then low hemoglobin and platelet counts. And then peripheral blood flow cytometry shows 21% myeloid blasts. The bone marrow spirit confirms the diagnosis of acute myeloid leukemia, and the cytogenetics showed translocation 6-9, and molecular testing was positive for a high FLT3 ITD allelic ratio of 0.6. So just wanted to highlight that this both translocation 6-9 and FLT3 ITD make her a high risk AML patient. And then subsequently, based on the diagnosis, she undergoes induction 1 and 2 therapy with anthracycline, cytarabine, etoposide, and then in addition of sorafenib for FLT3, and then gets mitoxantrone in second cycle, and then continues intensification 1, followed by the plan to undergo match unrelated donor transplant with busulfan and cyclophosphamide conditioning in CR1. So based on the treatment details I provided, this will be her cumulative exposure of different chemotherapy agents. I have highlighted the cumulative doses for anthracycline, daunorubicin, and mitoxantrone, and then also cytarabine, etoposide, and busulfan, and cyclophosphamide. With that, I will share a question that you may all have, and I will also give you the answer to that, and then we'll describe why this one answer is the correct one. And I would also like you all to think about the answer in your head so that you can, when you come across similar patient in your clinical practice, you know how you can manage this patient. So based on the planned treatment and cumulative doses, this patient would be at highest risk of which of the following: cardiomyopathy because of anthracyclines, pulmonary fibrosis because of busulfan, neurocognitive sequelae because of cytarabine, and then treatment related acute myeloid leukemia because of alkylators. And the correct answer will be cardiomyopathy associated with anthracyclines. And in next few slides, I will explain why that is the right answer. So this patient is going to receive daunorubicin and mitoxantrone as part of her chemotherapy course, which are anthracyclines antibiotics. They are known to be associated with cardiotoxicity, specifically cardiomyopathy, subclinical left ventricular dysfunction, congestive heart failure, and arrhythmia. The risk of cardiotoxicity is directly correlated with the dose of anthracycline. Typically, patients who receive more than 250 milligram per meter square are considered to be at high risk. In this patient, to calculate the cumulative dose, we have to use the calculator that is shown in the box on the right to come up with the doxorubicin equivalent dose. Based on the most recent reports, mitoxantrone dose is usually associated with 10 times higher risk of cardiotoxicity than doxorubicin, and daunorubicin is 50% less toxic. So based on that formula, this patient will be getting 555 milligram per meter square of doxorubicin equivalent dose, which puts her at a very high risk of cardiotoxicity occurring either early or late in after completion of therapy. There are 3 papers that I will highlight here, which have shown the incidence and risk factors of cardiotoxicity in patients with AML. And all of the studies have slightly different definitions of cardiotoxicity, but overall shows high incidence of early and late cardiotoxicity. So the first study used children's oncology group data who participated in this specific AML trial called AAML 0531. And the study showed 12% incidence of short-term cardiotoxicity within 5 years of follow-up, and majority of patients developed that while they were on therapy. The second study is from a French leukemia cohort called LEA cohort, and it's a prospective long-term follow-up program of all acute leukemia survivors treated at their participating centers since 1980. And this study specifically focused on AML survivors and noted 27% 15-year cumulative incidence of cardiotoxicity. Um, and anthracyclines were associated with cardiotoxicity, and higher hazards were seen in patients who got more than or equal to 460 milligram per meter square of anthracyclines. And then the last study is from the Nordic NOPHO AML cohort, which is a population-based cohort of AML survivors treated on Nordic protocols. And they compared the cardiotoxicity with non-cancer controls and found that a median of 11 years from diagnosis compared to controls, survivors had a significantly lower fractional shortening and ejection fractions. And again, the cumulative dose of anthracycline was associated with these outcomes. So how do we prevent this cardiotoxicity in the population? So there has been a drug, dexazoxane, which is a US FDA approved drug for preventing anthracycline-induced cardiotoxicity. Its approval was restricted to metastatic breast cancer patients receiving more than 300 milligram per meter square of doxorubicin. And in 2014, it was designated as an orphan drug for prevention of cardiomyopathy in children and adolescents of age 0 to 16 of age treated with anthracycline, allowing its use in pediatric AML. However, in past, there was some concern that there was a higher likelihood of secondary malignancy and relapse of AML in patients treated with dexazoxane. And then because of that, in July of 2011, European Medicines Agency released a statement restricting its use in only adult patients with cancer. However, that subsequently, that contraindication was lifted in 2017. So dexazoxane, it simulates selective degeneration of topoisomerase 2 beta, and then thereby reducing the DNA damage and oxidative stress. Typically, the dose is 10 to 1 for doxorubicin. So for 1 milligram per meter square of doxorubicin, we should be giving 10 milligram per meter square of dexazoxane. However, with mitoxantrone, the dose is higher due to higher risk of cardiotoxicity. So it will be 40 to 1 ratio. There have been studies looking at the impact of dexazoxane on preventing cardiotoxicity. So a study from the Children's Oncology Group showed a short-term reduction in left ventricular systolic dysfunction in patients who got consistently exposed to dexazoxane versus those who did not. And the table on the left shows the hazard ratio of cardiotoxicity in those patients that were lower in patients with dexazoxane exposure. The graph on the right shows temporal trend in ejection fraction with dexazoxane exposure. And blue line shows the patients who got consistent exposure versus red who did not. And you can see that the longitudinal trends were significantly different among both of those groups over time. A few studies have also looked at the benefits of dexazoxane on long-term cardiotoxicity. So it is important to note that these papers were only focused on patients treated with dexazoxane when they had acute lymphoblastic leukemia or Hodgkin lymphoma. This data is still coming from Children's Oncology Group, where they found that at a median of 18 years since diagnosis, lower odds of low ventricular dysfunction or low ventricular function in those exposed to dexazoxane compared to those who were not exposed to dexazoxane. Data from COG studies have also not shown any significant difference in overall survival, risk of relapse, or subsequent neoplasm between patients who got dexazoxane versus who did not. So based on all these studies, in 2022, a group called International Late Effects of Childhood Cancer Guideline Harmonization Group, or IGHG, stated that the benefit of dexazoxane probably outweigh the risk of subsequent neoplasm, especially when the cumulative doxorubicin or equivalent dose is at least 250 milligram per meter square. So with that discussion about the cardiotoxicity, let's go back to the case. And now our patient has completed her 3 rounds of chemotherapy and was supposed to undergo match unrelated donor stem cell transplant. However, unfortunately, she lost her donor. And as a backup, she is now being worked up to undergo umbilical blood, cord blood transplant, and the conditioning will be changed. Instead of busulfan cyclophosphamide to TBI, cyclophosphamide, and fludarabine. Um, and subsequently, once she undergoes transplant, her course gets complicated with several infections and leads to multi-organ dysfunction requiring mechanical ventilation for a period of time. She also gets veno-occlusive disease of liver requiring peritoneal drain, disseminated adenoviral infection requiring renal dialysis due to consistent use of cidofovir, and then ongoing graft versus host disease of skin and GI tract requiring prolonged course of corticosteroids. At 9 months, when we see her in clinic, she's 11 years old and she's still Tanner 1 and has not started going through puberty yet. And there is no change in her height since her transplant. So based on the changes in the treatment exposures, this will be her new treatment exposures. Mainly, I would like to highlight the changes in her cyclophosphamide, TBI, and then fludarabine. So the next question that we may have is based on the treatment history and clinical findings that we have, what would be the immediate concern? Would that be her growth impairment, gonadal dysfunction, low bone mineral density, or need for reimmunization? And the correct answer would be growth impairment. So with the change in conditioning regimen, the patient received 13.2 gray myeloablative TBI regimen, which is known to be associated with a wide range of complications, specifically affecting endocrine organs, metabolic health, mucocutaneous organs, lung, renal, and musculoskeletal system, and also a risk of cataracts and subsequent neoplasms. Uh, while the patients who develop this, patients who receive the TBI are not at high risk for all of them. However, I will highlight a few of the common complications in next few slides. And I will also mention that the time to onset of these complications is variable for each of this condition. So in 2000, a paper from St. Jude Children's Research Hospital highlighted various complications, including endocrine dysfunction in 77 patients with AML who were treated with chemotherapy, cranial radiation, and hematopoietic stem cell transplant. The table shows that the growth abnormality were seen in half of the population, and the greatest decline in height and weight Z-scores were noted in patients treated with total body radiation. Growth hormone deficiency was seen in 5% of the entire cohort, but it was 27% of the transplant cohort. And incidence of hypogonadism, hypothyroidism, and infertility were also high in transplant survivors. Another study from France specifically compared the growth impairment in patients who get transplant using busulfan-based conditioning versus TBI-based conditioning. And the authors saw that overall a larger change in height, um, standard deviation over time in those exposed to TBI versus those exposed to BU-PSY conditioning. The projected risk of growth impairment was 22% in and 36% at 5 and 6 years in TBI group, versus none in the BU PSY group. Uh, so this is again important to note that TBI in the population can really lead to significant endocrine late effects. And there have been some efforts to eliminate TBI in the transplant population, especially for AML. And unfortunately for this patient, because of the cord blood transplant plan, we had to use TBI, so that this is important to note what complications can affect this population. Other complications for the impact of radiation is on gonadal dysfunction. The graph on the left shows cumulative incidence of non-surgical menopause in childhood cancer survivors who were enrolled in the childhood cancer survivor study, exposed to alkylators and radiation exposing ovaries. And for those patients, the incidence of non-surgical menopause approached almost 30% by age 40. So based on this data, the IGHG guidelines recommend counseling for the risk of menopause or premature ovarian insufficiency and its implications on fertility in those treated with alkylators and radiation, potentially exposing ovaries. And in pre and peripubertal survivors, surveillance through monitoring of growth, pubertal development and progression, and then also using FSH and estradiol lab tests for those who fail to initiate or progress puberty are also recommended. While we are on the topic of growth and gonadal dysfunction, it is also important to discuss the risk of low bone mineral density in patients who get exposed to corticosteroids and transplant particularly. So the magnitude is variable by the age and corticosteroid potency, and the risk could be exacerbated in patients with predisposing conditions such as hormone replacement therapy for hypogonadism or growth hormone deficiency. Z-score of more than 2 standard deviation below the mean in male survivors, you know, we usually look at this by doing DEXA scans, and because of all those risks, we have to do serial DEXA scans, both early, because it can be both early and late complication after transplant, to make sure that they are not having low bone mineral density. And if we notice low bone mineral density, these patients may benefit from treatment with calcium, vitamin D, and sometimes even bisphosphonate therapy. One of the other answer choices in our previous question was need for re-immunization. So it's a big topic to cover in this webinar. However, I would like to highlight this one paper that was published in 2016, which shows a schema on how to revaccinate patients after transplant. The authors recommend revaccination at 1 year time point if patients are all off all chemotherapy and not receiving any CD20 directed therapy such as rituximab, and don't have any moderate or severe graft versus host disease, and also not receiving any IVIG replacement. In our patient, because she still had evidence of graft versus host disease, this patient would not be considered for vaccinations until 1 year time point. And I would highlight a few papers that I usually used when on deciding when to vaccinate our patients. And some of these are open access, so I would highly encourage you to look at these references when you're taking care of your patients. Uh, Next question about our patient. So based on the complications that patient had faced, and I would remind you that they were she had mechanical ventilation because of multi-organ dysfunction with sepsis. She also had a veno-occlusive disease of liver, and then also had renal dialysis after requiring treatment for adenovirus. So which of the organ function would be more important to assess when she enters long-term follow-up. Would it be liver, lung, kidney, or all of the above? And the answer would be all of the above. Um, given the exposure of cyclophosphamide and transplant, this patient would be at risk for hemorrhagic cystitis in early post-transplant period. And then also long term, this patient would be at risk for bladder fibrosis, dysfunctional voiding, vesicoureteral reflux, hydronephrosis, and also renal insufficiency and glomerular and tubular injuries. These patients are also at risk for hypertension because of their kidney damage. And the risk is variable based on the specific outcome, preparative regimen, and then also previous history of any viral infection such as BK or adenovirus. And this one, if they have early post-transplant renal complications, they can persist long term, and they should be monitored closely for their renal function in long-term follow-up. Similarly, because of this patient's treatment history of TBI exposure, this patient would be at risk for pulmonary fibrosis and also interstitial fibrosis, restrictive lung disease, and obstructive lung disease. And the patient should be getting serial assessment of lung function by pulmonary function testing. Again, the risk varies by age, history of chronic GVHD, infections impacting lung function, and also health behavior such as smoking or vaping. There is not a lot of literature on this topic, but history of mechanical ventilation can also lead to long-term pulmonary dysfunction in this patient population. And then lastly, for the liver function, because of the previous history of VOD and then also transplant, this patient would be at risk for long-term liver toxicity such as cirrhosis, iron overload, focal nodular hyperplasia, cholelithiasis, and hepatitis. And this patient should be getting serial liver function testing to monitor their liver function after entry into a long-term follow-up. And then again, the risk would be very variable based on their prior treatment complications, GVHD, number of transfusions they have received, and then also any acute post-transplant toxicities such as VOD. I would also like to highlight this one paper that is from the Center of International Blood and Marrow Transplant Research, or CIBMTR, which looked at the higher risk of morbidity and mortality in patients who had prior ICU stay in early post-transplant period. And the Kaplan-Meier curve shows this the data linkage of CIBMTR and with the virtual pediatric systems database, which is a database of ICU hospitalizations across the US. And the study showed that the cumulative incidence of ICU stay was 15.3% in by 5 years in transplant survivors. And among one-year transplant survivors who had a history of ICU stay had 10% lower survivor at 5 years and had fourfold increased TRM burden compared to those without the history of ICU stay. And ICU stay was also associated with several other organ dysfunctions such as renal failure, diabetes, liver toxicity, stroke, seizure, and non-infectious pulmonary complication. So now going back to the case again, let's say this patient is 2-year post-transplant and is 12 years of age. She has now evidence of chronic graft versus host disease of skin and remains on immune suppression. She is undergoing catch-up immunization. She's currently in her middle school and reports being teased because of her physical appearance that has changed due to her GBHD. And then also she's having difficulties understanding her assignments in her school. So based on those details, what would be the most important test for her that should be considered at this time point, whether it is audiologic assessment, brain MRI, neurocognitive assessment, or both audiologic assessment and neurocognitive assessment? And the answer would be A and C. So this patient has received prior high-dose cytarabine and also TBI exposure, and both of them are associated with significant neurocognitive deficits. And these patients can have problems with their executive function, attention, memory, processing speed, and also can even affect their overall IQ. The magnitude of this complication can be variable, and it can happen at any time point between months to years after the exposure of this treatment. There has been a study in the past, a single center study from St. Jude, which compared the IQ of patients who got TBI-based conditioning for transplant versus those who did not. And the graph on the left shows overall IQ change from at baseline, then 1 year, 3 year, and 5 year post-transplant. And the study found that the TBI and young age at exposure to TBI were associated with IQ decline. And those who had were not exposed to TBI actually had recovery in their IQ over time after transplant. So again, this makes another case for reducing or eliminating TBI exposure in transplant as much as possible, especially in AML population. In ALL, the studies that have tried to do that have not been successful, but in AML, that has been possible. The based on the impact of the treatment and transplant and radiation on neurocognitive function, that can subsequently have downstream impact on patients' educational and employment outcomes as well. The studies have shown impact of treatment on educational attainment, need for failed or repeated grade, and also need for special education. And based on that, the IGHG guidelines recommend a regular surveillance of all educational outcomes in cancer survivors, including AML patient population. And that the educational problems should be appropriately documented in medical records, and referrals should be made to educational specialists, psychologists, and other specialties such as social worker as needed. It is also important to note that because of radiation exposure, these patients can also have concurrent ototoxicity, and they might be also getting various other medicines such as antibiotic that can affect their hearing as well. And that should also be ruled. Hearing deficit should be ruled out, especially if they are having problems in school. At this time, I would also like to highlight other risks associated with chronic graft versus host disease. As I mentioned that our patient is dealing with that for especially affecting the skin. It's again a huge topic to cover in this webinar, so we can't go in too much depth here. But patients with chronic GVHD can be at risk for various complications depending on the organ involvement, and also can have immunologic complications as listed here. These patients can also be at risk for significant impact on their quality of life. So now our patient is eligible to transition to adult LTFU. She is between 18 to 21 years of age, so we can then think about transitioning her care. She has completed her high school with the help of educational accommodations. She's now taking a break from education and actually working at a local store. She doesn't have any issues with chronic graft-versus-host disease and now is off immune suppression. So as she goes into adulthood, family wants to know about what other complications she might be at risk for developing long term. And what would you think would be the risk here? Would it be hypercholesterolemia, hyperglycemia, obesity, or all of the above? And again, the answer would be all of the above. So we know that from previous studies that patients with transplant survivors are at high risk of obesity, dyslipidemia, hypertension, and glucose metabolism issues. It is important to note that transplant survivors specifically have sarcopenic obesity, so their BMI and waist circumference might be of normal range, but they could still have lower lean mass and higher adipose tissue, as you can see in the figure on the left. There are several risk factors associated with metabolic syndrome at various stages of treatment, and immune system also plays a role in propagation of that post-transplant. There is this study from Memorial Sloan Kettering, which looked at transplant survivors treated with TBI and the cumulative incidence of various complications. And you can see that the 5-year cumulative incidence of hypertension was for almost 15%, elevated glucose nearly 11%, low HDL 27%, hypertriglyceridemia 39%, and obesity 16%. And there were patients who had more than or equal to 10, almost 10% had more than or equal to 3 of these risk factors. And the cumulative incidence increased to 28% at 10 years post-transplant. So there has been a lot of research interest in looking at lifestyle and improving lifestyle and the impact of that on mitigating this metabolic syndrome and other cardiovascular risk factor complications post-transplant. This figure is from the Childhood Cancer Survivor Study, which looked at the association between physical activity and self-reported quality of life. And patients who were doing more physical activity or more vigorous exercise had less impairment in their quality of life in physical, mental, and social domains. Quickly, the other couple of topics to discuss that we haven't touched on yet. This patients, because of history of transplant, exposure to various chemotherapy and especially radiation, would be at high risk of subsequent neoplasms. The figure on the left shows the hazard of subsequent neoplasms according to the total body radiation dose use. And you can see that the TBI dose higher than 4.5 gray was significantly associated with the risk of subsequent neoplasm. The figure on the right shows the risk of breast cancer in patients who have undergone transplant using TBI-based conditioning. And the risk continued to increase even with higher attained age and was higher for those associated exposed to TBI. And then lastly, I will also highlight the impact of transplant on their quality of life. The figure is from comparing health outcomes in transplant survivors who were enrolled in a cohort called Bone Marrow Transplant Survivor Study, survivors treated with non-transplant chemotherapy enrolled in Childhood Cancer Survivor Study, and then a general population sibling control group. The study found that 13% of the transplant survivors had self-reported poor general health, 18% had functional impairment, and almost 29% had activity limitations. And the impairment were highest in patients who had received transplant and had active chronic GVHD. So those are all the things we know about from the literature we have had so far. But there are several things that we still don't know about the risk of long-term complications in patients treated with for acute myeloid leukemia. So there have been several new drugs coming to market recently, both for pediatric and adult AML treatment. And we still need to follow this patient systematically to understand how these patients will be affected by the side effects. So there have been, this just figure shows how various drugs are affecting patients' AML blast cells from different mechanisms, and they may have potential off-target toxicities that need to be monitored. And there is also increasing interest of using CAR T cell therapy in this patient population as well. And then lastly, while we know that patients who get treatment exposure and also have risk factors from their lifestyle are at risk for late complications. However, there is still an unknown topic of how underlying genetic mutations also predispose patients at risk for these complications. And there is more work happening to understand this, but however, it will take few years before we can really understand this interplay of various risk factors, and hopefully we can use that information to potentially change treatment upfront for patients who might be at higher risk compared to others. So there has been work to look at the gene associated with pharmacodynamic and pharmacokinetics of anthracycline metabolism and how it impacts the risk of cardiomyopathy. There have also been some other studies looking at pharmacogenetic of cytarabine, etoposide, and then gemtuzumab. However, we still need to do a lot of work before we can make strong conclusions based on that. So with that, I will conclude. I hope I have been able to discuss that treatment of AML significantly impacts pediatric patients' long-term health. They have unique lifelong repercussions, especially when they are treated in pediatric age range because they have a long-term lifespan ahead of them. Anthracyclines remain a cornerstone of AML therapy and have a lot of complications, especially cardiomyopathy. There are also several complications if the patients are treated with total body irradiation. And then there is also increasing role of novel immune-based therapy, which are promising. However, we will need to follow these patients systematically so we can determine if they have early and late complications. And with that, I'll thank everybody for your attention, and we'll be happy to take questions.
Hey, Neil, thank you so much. Thank you for your top-class presentation. As expected, we've received several positive comments and several thoughtful questions. Unfortunately, we won't have enough time to address each individual question, but I'll do my best to summarize and incorporate a few key ones. Our first question is, how in your clinic, I'm reading the question directly, how in your clinic you monitor cardiac status, and how much cumulative dose of do you give equivalent, and what biomarker you follow?
That's a great question. So for the pediatric population, we usually follow Children's Oncology Group guideline, which is published every 5 years. And currently we are in version 6.0, which was published just last year. And that guideline provides a very clear recommendation about how to monitor cardiac function after end of therapy, especially when they are exposed to anthracyclines with or without radiation exposure. So the way we follow these patients are doing serial echocardiograms anywhere between 2 to 5 years at 2 to 5 years frequency, and the we continue to do that lifelong because the guidance from the previous study, the literature shows that the risk does not improve over time. It actually continues to be high. And there have been several cost effectiveness study done to justify this serial echocardiograms. And based on that, we try to uh, prevent this cardiac dysfunction. And if it is happening, we can catch that early and potentially use cardiac remodeling agents to reverse the course. There have been some trials on using ACE inhibitors or beta blockers to in that situation. Um, Unfortunately, we haven't got to a point where we can reduce preemptively anthracycline exposure. If so, we previously there have been some discussions on how to reduce the dose of doxorubicin or idarubicin upfront, so we can reduce the risk of cardiotoxicity. However, we haven't been able to successfully do that. There have been, however, some interest in using liposomal formulation of anthracycline and cytarabine. There is a drug called CPX 351, which is being studied in pediatric AML at this time. So we are hoping to use some novel agents to reduce the risk of cardiotoxicity. However, we know that anthracycline remain a cornerstone of the therapy, and it will take some time before we can try to reduce the dose.
So next question is from Mona, our well-wishers. Is there a role of CAR T cell in AML treatment, and will novel treatment replace need for transplantation in pediatric or childhood acute myeloid leukemia?
So I am actually a transplanter, so you'll get a biased response from me. I think even with CAR T cells, we have noticed that they are not going to be the complete answer. We especially with the data in acute lymphoblastic leukemia, a lot of our patients who get CAR T cells in pediatric ALL eventually come to transplant because of one reason or the other, including loss of B cell aplasia or some other CD19 negative relapse and things like that. It is still an ongoing challenge to find a specific target for patients with AML. People have tried various CD markers, including CD123. However, I feel that it is still not ready for prime time yet. And even when it gets to that point, I feel transplant will still need to be an important consolidative therapy for this patient population.
Next question is from Professor Revati Raj, one of the famous hemo transplant physician, pediatric in the India. Is there a difference between 3+7 and ADE regimen with late effects?
Um, That's a great question. I don't know if anybody has looked at that comparison directly. Um, but that would be important to look at to see if there is any way we can change the treatment up front. The data I showed is mostly from the US group. So I showed the regimen that we usually use in our setting, but I think there is definitely there will be interest in understanding if regimen differences can lead to reduction in late effects.
So last two quick questions. One is FLT3 TKD mutation in pediatric AML is favorable or unfavorable? This is from Dr. Karthik.
It is unfavorable, especially when you have a high allelic ratio. So we also notice that sometimes they are uh, coexisting with other mutations. So combination of both can also increase the risk. We are typically using sorafenib as our treatment agent for FLT3 ITD patient population. I know there are several other treatment agents that are being studied, including gilteritinib that was studied recently in post-transplant setting. So there is more research to come in that field, but it is considered a high-risk population for pediatrics.
This is last questions on survivorship. So at Fred Hutch, how do you manage or what is your SOP on transition of adolescent or childhood survivor to adult survivorship clinic? Do you have any specific tips you can give it to our audience?
Yes, that's a very, very important topic, and something that we are, trying to improve, and we have been able to make some progress there. So, in at Fred Hutch, we have pediatric survivorship clinic at Seattle Children's Hospital, where I see patients who have been treated with chemotherapy and or transplant and follow them serially at least every year up to the age of 18 to 21. And we then transition them to our Fred Hutch Adult Survivorship Program, and we can transition them to either the adult LTFU program, which is mostly focused on transplant population with or without the history of graft versus host disease, or we can refer them to adult cancer survivorship clinic if they are so far out from their transplant or they haven't been treated with transplant. And myself and Dr. Paul Carpenter, both of us are able to see patients across both clinics, so both in pediatric and adult clinics. So that provides continuity of care for this population. And we continue to follow them long term in the adult side. Usually, we try to see when they are ready to transition. It can happen anywhere between 18 to 21 years of age. We try to make sure that their all the subspecialty care is covered by then, and they have a really strong PCP who is also going to take over some of their care before transitioning to adult side, because in adult side it would we because of the number of patients, we may not be able to provide the same level of care where owning all the survivorship care as we do in the pediatric side.
Neil, thank you again for disseminating the knowledge to help our patient. I wanted to thank all our live audience for joining the webinar. And for those not able to join, full recording with slide of recording webinar will be available on ISCH website in next 24 to 72 hours. This is in line with our mission of Hematology Without Borders. When anyone can view all past recording anywhere in the world, anytime. Thank you all again. Thank you, Neil, again.
Thank you.